Welcome to the EAU podcast series, Present and Future of Diagnostics in Prostate Cancer. In this first episode, we are joined by Juan Gomez Rivas, a urologist at the Hospital Clínico San Carlos in Madrid and associate professor at the Complutense University of Madrid, Spain. Also, Dr. Elena Castro, a consultant medical oncologist at the University Hospital October 12th in Madrid, Spain. Together, they will discuss genomics and biomarkers in localized prostate cancer. Join us as we embark on this informative journey.
Welcome, everyone, to the listeners of the EAU podcast. And we will be talking about genomics and biomarkers in localized prostate cancer. With me is Dr. Elena Castro. Elena, how are you?
Very happy to be with you here today, Juan. Thank you for inviting me.
No, thank you for joining us. So let's start talking about genomics and biomarkers in prostate cancer. So my first question to you would be why this topic is essential in the evolving landscape of prostate cancer diagnosis.
Well, I think we are all very aware that prostate cancer is a very heterogeneous disease. So even when we have traditionally classified prostate cancer based on some clinical parameters or clinical features and PSA levels, PSA kinetics, and then we divide prostate tumors in different groups based on these characteristics. We know that within each group, there are tumors with very different behaviors. So what we try with the use of biomarkers is actually to identify those other features that will allow us to obtain perhaps a more homogeneous grouping of those tumors, and also to identify which could be the best treatment for these patients who have a certain prognosis.
I think that nowadays we have a problem in prostate cancer, specifically in localized disease, because the definition of localized disease is based mainly on clinical features, that is PSA, imaging, and of course, the information that we get from the biopsy. So there's a limitation in the traditional methods that we have to determine prognosis and our treatment strategies. So I think it's important, this topic of genomic and biomarkers. But we were talking about this before the recording. There is a difference between genomics and what we have regarding biomarkers in localized disease. Can you tell us something about that, Elena?
Well, this is just perhaps a very academic discussion, but usually when we refer to genomics, we are talking about alterations in the DNA, mutations, gene deletions, gene amplifications, for instance, BRCA2 mutations, AR amplification, SPOP mutation. When we talk about RNA expression patterns, we are talking about transcriptomics, expression profiles. So we currently know that there are different groups. We can divide prostate tumors and other tumors into groups depending on the genes that are highly expressed or express less. And these signatures have been correlated with prognosis. Also, genomic alterations have been correlated with prognosis, but these are very different things. And the commercial assays currently available, some names of these are Prolaris, Decipher, Oncotype. I know there are several others. I just want to provide some examples. These analyze RNA and classify tumors based on those RNA expressions. So it's slightly different, but I think it's important to keep that in mind.
Thank you, Elena, for this clarification. And let's move to talk about specifically in localized disease. We know that the prevalence of germline mutations in early prostate cancer, let's say, is quite uncommon, is around 5% or even less. By the time, do we have any data or anything that we can rely on saying that we need to do this test in localized disease? Or Does this test translate by the time any clinical background in our patients with localized disease?
Well, there is an incremental increase in the prevalence of these germline alterations from low-risk localized disease. In this population, the prevalence of these alterations is the same as in the general population, which is around 2%. And is significantly increased in high risk or very high risk localized prostate cancer. That is, as you mentioned, around 5-6%, depending on the genetic background of the population. And this is similar to what we see in metastatic prostate cancer. And this is why guidelines recommend germline testing in patients with high or very high localized disease and not so in patients with low risk disease. So there's some retrospective data that demonstrated that patients with germline BRCA2 mutations who were managed on active surveillance were more likely to have a tumor progression in the form of a higher Gleason score at the time of the follow-up biopsy than patients without these germline BRCA mutations. And this has prompted that some colleagues recommend that patients with these germline mutations should not be managed with active surveillance. So we only have data from that retrospective analysis that included few BRCA patients, around 12 patients in a cohort of 1,100. Other colleagues say that this is not an absolute contraindication carrying a germline BRCA mutation. What you just need to do is to counsel the patient accordingly, let him know that his risk of disease progression is higher. But if he's a very young man, a very young patient who could be on active surveillance for 3-4 years before requiring radical treatment, it could be relevant for this man to avoid certain side effects that could be concerning for him. So we need to be aware that these tumors are more likely to progress, but I personally think that it shouldn't be considered an absolute contraindication.
Okay, so we can conclude on this regard that by the time we do not have enough data and we do not have any rationale to drive our treatment in at least in low risk localized disease based on carrying this kind of germline mutations. Is that right, Elena?
Yes, this is at least that is my opinion. And the reason to recommend germline testing for patients with high risk or very high risk is perhaps not so much to decide the management of the disease, because currently there's nothing like PARP inhibitors approved in this scenario. The only data to decide between surgery or radiotherapy is a retrospective study that we conducted a decade ago, and the radiation techniques have evolved, and so we only have that retrospective data. But the reason to recommend germline testing to these men is to identify other family members who could be carriers and could be at risk of prostate or other tumor types, such breast cancer or ovarian cancer in the case of women. So for cancer prevention or early identification purposes.
So perhaps what we have nowadays in localized disease, and mainly in those patients with low risk, to make our decision on doing or not a radical treatment, or if we have any concern, is this test called, for example, ProLatis, Oncotype, Decipher, ProMark, Prostatype, where you already explained the mechanism here that is not genomics themselves, is ARN or other kind of measures that can evaluate the risk of having an adverse pathology specimen if the patients undergo radical treatment, for example, or the risk that the patient have on having biochemical recurrence after a radical treatment, so we can change our clinical decisions. We know that these tests, at least in Europe, are not wide expanded, perhaps because of reimbursement problems. But in other places, such as the United States, they are very well used and very well known. In mainly of these tests, also is not only fancy, let's say, measurements of ARN, or they call also genomic prostate scoring systems. They also mix our clinical data, such as digital rectal examination, PSA, and Gleason score, and they can drive our decisions or help us in the decision of our patient when we have them in the clinics and decide what would be the best for them. Moving a little bit of this topic, Elena, and perhaps also to give a nice close to this podcast, what do you think would be the future of this genomic profiling in localized disease? Where are the investigations running now by the time?
Well, for genomic assays, we still need to demonstrate that, prospectively demonstrate that, for instance, BRCA, not just germline, but also somatic alterations are prognostic. So it has been demonstrated in different tumor settings. So probably is very likely also to be true for localized disease, but still the magnitude of the difference in outcomes between patients with and without these alterations is unclear. On the other hand, it seems that SPOP mutations are associated with good prognosis. So we will need analysis of prospective validation of these results to be able to decide whether a patient with BRCA alteration requires further adjuvant treatment, and there are some studies ongoing, or whether patients with SPOP alterations perhaps don't need other adjuvant therapies, are less likely to progress. And like that, other alterations in other genes such as PTEN or RB1 or MYC amplification, etc., etc., etc. These are alterations identified in the tumor, because in advanced disease we have ctDNA. We can detect these alterations in ctDNA. The problem we have with localized disease is that in general the circulating DNA, this is ctDNA, is very low. So the use or the future utility of ctDNA in this scenario is probably not very useful, at least with the technology we currently have. Something that could be very interesting is that if we were able to monitor that, and at some point we see that the ctDNA goes up, we will be able to identify disease progression before then observing that in imaging, right? But these studies, this is still research, this is still, everything is still ongoing, or we could use it also to identify changes in the disease progression, but this is still ongoing. There is also some, these tests, these transcriptomic tests are also being used in around radiotherapy. And just last week at Assoc GU, we saw how the PORTOS signature correlated with the benefit of escalated radiotherapy dose. All these assays are being tested in different scenarios. And finally, we have the artificial intelligence that the Artera tests, for instance, have demonstrated to be quite useful in predicting who are the patients with intermediate disease who may benefit from ADT in the context of radiotherapy as well. So it's a lot coming in this way of different biomarkers for localized prostate cancer.
Thank you, Elena, for these insights. For me, is the future will be brilliant, of course, in localized disease, but at the same time, I think it's quite challenging or quite difficult to find a better biomarker, at least for follow-up rather than PSA. Prostate has a very good biomarker that we can use in follow-up, which is PSA. We know that in diagnosis, is not that good. It's good because we base our decisions a lot in PSA, but for follow-up, it's very, very good biomarker. But I hope that in the future we can get better with all what you have mentioned. To recap the key points discussed in this episode, Elena, we say that nowadays this kind of genomic profiling in localized disease, we cannot use it to make our clinical decisions by the time, at least in low risk. In high risk, we have a profile of patients that can be screened for this in order to make our decisions of follow-up and also on adjuvant therapy. And in the future, of course, targeting agents. Do you think there's a difference that we can do nowadays in our follow-up of our patients with BRCA, or if we need to change our screening of prostate cancer in those carriers?
Well, the current recommendation is that for men who carry a BRCA mutation, particularly BRCA2, we should start PSA screening around the age of 40. Some say that for BRCA1, we can wait until 45. There is a lot of discussion also about whether the digital rectal examination, in addition to PSA, really improves the ability to detect early prostate tumors in these patients. And there's also some studies that suggest that for mutation carriers younger than 65, follow-up or screening with MRI detects or helps to detect clinically meaningful tumors, because we need to remember that what happens with BRCA is that often these tumors do not rise PSA very much. The impact study shows that for men between 40 and 70 with PSA levels above 3, chances of finding a prostate cancer are around 45%, whilst for non-carriers, this is significantly lower. So we have to be careful, and when we know that a man carries one of these mutations and the PSA is slightly increased, be aware of their higher risk of developing the disease.
Well, we are almost reaching the last minute of our podcast. Elena, do you want to give a final remark or a conclusion or take-home messages to our listeners?
Well, I think, as you said earlier, we are entering a time when the analysis of the tumor, either mutations, genomic analysis, or expression profile, or even artificial intelligence, once it is available, is going to provide us with a lot of information. It has to demonstrate, all these assays have to demonstrate to be better than the variables we currently have, like PSA kinetics or conventional imaging or PSMA PET, etc. So it is meaningful for us to implement those assays in the clinic. But I believe we are going to be using this more and more.
Once again, Elena, thank you very much for making a gap in your time to be with us. And I encourage all your listeners to be engaged with our podcast series at the European Association of Urology. Thank you very much.
Thank you, Juan.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.